So taking a look at elbow, forearm, wrist, and hand radiology. This section, I will be perfectly honest with you, is not as difficult, not as rigorous as some of the other sections that we've gone over, especially in the context of things like the spine. But definitely make sure that you understand all the search patterns. We're still going to use our ABCs when it comes to radiology with this. Also understand that the elbow, wrist, forearm, and hand have a lot of eponyms. So you all know my opinion on eponyms, but just understand and realize that this section has an inordinate amount of eponyms as we move forward. So take a look at the quick objectives we have for this section. Just be able to identify things like bony landmarks. We're definitely going to do a lot of that both in the podcast format as well as Blackboard Collaborate, and just make sure you're familiar with each of those. So kind of a overall global perspective here. So many PTs are not getting a lot of elbow, wrist, and hand patients. I will say that a lot of times OT will get those referrals, but I have worked in many clinics where we didn't have an OT accessible. We live in a world where now PTs have more direct access than they ever have earlier in their careers or early in the history of the profession. So definitely make sure you understand elbow, wrist, and hand because you will be able to see these patients via direct access and throughout your careers. So in the theme of decision making for this course, this is straight out of Riemann's textbook. So really what I want you to do with this, just like we've done with the other decision making trees that we've used in this course, definitely take a look at the diagnostic test, take a look at the reference standards. Again, just like with some of the other orthopedic joints, as we can see, that reference standard is a scope or arthroscopy. So definitely make sure we understand what the reference standard is for a lot of these measures. Also understand that these tests a lot of times are not all 100%. So be very familiar with this. Obviously, we want to map this decision making tree onto the ACR criteria as well. And when we make decisions on what's going to be our first, secondary imaging choices, we also want to make sure that we understand why each of these choices of imaging modality are appropriate. So go back to anatomy, think about things like where the ulnar nerve is located in reference to the skin or reference to other um, structures. Take a look at things like the distal bicep tendon. Understand why an MRI, understand why ultrasound may be very appropriate for either one of those. We're going to do a unit later on ultrasound so you guys get a good sense and feel for how ultrasound works and how it could be beneficial in your decision making as clinicians. So the basics of elbow radiology, realize that we're going to have a couple of basic views here. We've done a lot of these basic views for other parts of the body. So be very familiar and be very confident with some of the radiology that we're going to use. Also start to become confident and competent with things like ultrasound, things like MRI, and CT scan. So as we have seen with other orthopedic joints, we're going to have some screenings. So big screening test for the elbow is a really simplistic test to do. It literally is the elbow extension test. It's called the elbow extension test because all you have to do is extend the elbow. And it's really nice because it has such good reference criteria. It has such good validation. So if the patient's age over 14 years or older, and you ask them to fully extend and lock out the injured elbow, if they're not able to, that's a positive test. That means we should go ahead and we should get a radiograph. So as you can see, of the 37 positive tests, all had a bone injury and one misplaced radial head fracture. So pretty good criteria. So take a look at this slide. Go back to anatomy class. Think about the anatomy that we're going to see in the elbow joint itself, and really get a good sense for how each of these structures would look on things like a plain film radiograph, how they would look on an MRI, how they would look on a CT scan. Those are going to be very different pictures. We're going to understand and realize where each of those structures are going to be viewed either through an AP or a lateral x-ray. So we need to be very confident when we're making these decisions. Like I've told you many times in the past, I'm not teaching you based on where this profession has been. I'm teaching you based on where this profession is going. So we need to be very confident with making those decisions as clinicians for diagnostic imaging. So what I would like you to do here is pause the slideshow presentation and think about how you would view and how you would order radiographs for each of these structures. So think about how you would view the head of the radius. Think about how you would view the olecranon. Because really when you're ordering that x-ray, you really need to be confident with what views are going to best give you those structures. Because obviously we don't want to expose our patient to any excess radiation. Also, we want to make sure that we are viewing the structures we need to view and we don't want to miss anything. So this is a picture of an AP view of the elbow. This is exactly how the x-ray would be taken. So we just need to make sure we understand where that x-ray beam is coming from and what structures, and especially understand that an AP elbow view is going to be taken in a supinated or anatomic position. So don't get confused when the forearm is in pronation versus supination. With an AP elbow, we need to make sure that forearm is going to be in full supination, or as much supination as we can achieve. These are the landmarks that we're going to see with an AP elbow view. What I would like you to do here, again, is pause the slideshow presentation, blind the answers, and be able to pinpoint each of those structures. Like I said, for final examination purposes, you're going to be asked to label a lot of images, and you're going to be asked to identify structures on different sorts of imaging modalities. So definitely make sure you're confident with that going into the final examination. So here what I want you to do, this is an AP view of the elbow. Pause the slideshow again. This is a great way to check that you know the structures. So definitely make sure you know the structures, understand the structures, and then when you feel confident, go back to the previous slide and check your answers. Like I said, there's going to be a lot of questions where you're going to have to label radiographs on the final examination. So another point I want to make here with the elbow specifically, and this is another anatomic variation that we have between males and females, is the carrying angle. Typically that carrying angle is going to be a little larger in females, so we definitely need to make sure when we're viewing the elbow in the AP sense that we know if we're looking at a male elbow versus a female elbow, because the last thing we want to do is misdiagnose some sort of valgus deformity because we don't know what gender elbow we're looking at. So definitely make sure you're aware of that. This is how a lateral view of the elbow is going to be achieved. Like I've said earlier, the lateral view is going to place the elbow at about 90 degrees of flexion, and then we're going to view the elbow from the lateral to the medial side. So this is a difference that we saw elbow versus say like foot and ankle. So we definitely want to make sure we know where that x-ray beam is coming from and where that x-ray beam is going to. That's going to really determine things like attenuation and obscurity when it comes to viewing radiographic images.